Hello, everybody. Here is Chapter 32, Care of Older Adults. Let's get started. Okay, description of aging. When caring for older adults, it's imperative to avoid making assumptions based on age-related myths. Some myths would be that old people are cranky, old people are senile, old people are invalid, they don't do anything anymore, they're not interested in things anymore, and that is all myths. Another myth is that, or that I want to hit on, is that the senility. Just because you're getting old doesn't mean that you lose your ability to focus or your ability to remember. Okay? The term elderly now may be considered offensive, so you don't call people elderly or old, because it implies weakness, fragility, or mental incompetence, although some people would use that they're elderly as an excuse. Some of our elderly people have lost their filters, and they'll say whatever they want to say, and it's because, well, they've gone to that age and they have no filter. But that's not an excuse either. Persons in later adulthood are unique and individual and should be assessed holistically. So we just don't put them all in one crowd that they're all elderly. We have to look at each and every one and know what their abilities are. Classifications. You're a young old if you're 65 to 74, middle old 75 to 80 or 75 to 84, old is 85 and older, and centurions are 100 and older. Young old, there's a gradual decline in physical health. The blood pressures go up, their cholesterols go up. Many get diagnosed with diabetes too. Many are still working, probably because they can't stop working because of the economy. They're the ones that are filling the holes in McDonald's and Walmart. You see them at AutoZone, delivery for AutoZone, delivery for Domino's. They just need to supplement that income because the Social Security is just not enough. So they're working, they're volunteering, they're maintaining their friendships. Middle old, they're generally retired. They've had death or some loss in their life. That could be their friends, their family. There's an increased depression, and there's the changes is a disability where they can't do their hobbies like they used to. Okay, maybe because their fingers are a little bit older, they can't move as much. Their gait is a little bit impaired possibly, so they can't continue to do their hobbies. Old, significant decline around the clock care, generally around the clock care. Of course, there's those that don't need the round the clock care, and that's where we have to look at each one individually. So at this point in time, they try to figure out facility versus home care. Remember that middle adult is considered the sandwich. They have people at home, and then they also have people to take care of, which is their parents. And it's a tough road to be in the middle of. National Institute on Aging, today 8.5 people worldwide are 65 and older. By 2050, this is expected to jump nearly 17%. And there could be a reason for that. It's because we're treating chronic illnesses better. We know what causes chronic illnesses, and we're trying to get people away from that, and therefore people are able to live a little bit longer. The Health Resources and Service Administration projects that the supply of nurses in the United States will fall by more than 1 million below the requirements needed to care for the population. Kind of scary, huh? Now, when you get old, so that's about 27 years from now, you'll still be working, probably. Most of you will. You will be in high demand, for sure. Extensive intervention must be accomplished to recruit and retain more nurses. And they're trying. They really are trying to retain the nurses. It's easier to retain a nurse than it is to bring another nurse in and have them train what is it? I think they figured out that each person that they train and hire, it's over $10,000 per, and that's a low ball money, $10,000, and that's recruiting, and that's interviewing, all that. So it's easier just to keep somebody. Imagine if we sat there and we said, well, we really want you, so we're going to give you $10,000 that we would normally have spent on a recruit. Because remember, we can recruit new bodies, but we can't recruit experience. We lose that experience every time somebody retires or quits and goes to another job. Misconceptions about aging, ageism, the practice of discriminating and prejudice against older adults. We sometimes see it, and we shouldn't be like that. People won't hire some people because of the fact that they're older. When you start new careers, I've had students that started in nursing when they were in their 60s. I believe it after 65, it's free tuition if you want to come back to school. And they can do the job just as like anybody else. Will they go and be a floor nurse? Probably not. They might work at a doctor's office, community health, something like that. Okay, ageism there's stereotyping, unequal treatment in workforce, denial of healthcare. They cost more. So companies might not want to hire them because they cost more because they have more chronic illnesses. But again, that is ageism, and guess what? That's not necessarily true. There's some people that are in their 30s that have more problems than those in their 60s and 70s. Look, we have an instructor, her name's Rita Bowden. She taught here for 50 years, and she still teaches here. She takes a 101 nursing students to Salem. She's 74, I think. She's close to 74 or 75. Doesn't take any pills. None whatsoever. Totally no pills. It's amazing. And the woman never got sick either. They should actually take her blood and give a little of that blood to everybody. Treating all patients as individuals with unique characteristics and personalities, no matter what their age or of the patient. Okay, we see that we can do that a lot in long-term care. Sometimes in acute care we don't get to know them as well, but we still shouldn't lump them in all one category. Okay, older adults, it is important to keep the patient's special situations in mind. You have to know what's going on with the family, what they're doing at home, how is their home life. Older adults may have several chronic conditions, diabetes, COPD, peripheral vascular disease, okay? So that's why we have to know why they're coming into the hospital or into the office that day. Arthritis, arthritis, trying to think of something else that would be coming into the office. Heart, cardiovascular, the heart's wearing out. Avoid focusing on only the major complaint and take the whole person in consideration. Somebody comes in and they hurt when they walk. Maybe their knees are really bad. We have to look at the whole person. How many stairs do they have to go up? How much walking do they do? Do they have home health? Do they have hope? Do they have help at home? These are all things that we have to look at and consider. Okay, physiological effects of aging, changing in neurological functioning, reflexes come slower, they might have transient ischemic attacks. What that is basically, it's what we call a TIA, but think of it as like minor, like angina with our heart. If we have a decrease in oxygenation to the heart, we have angina, you get chest pain. Okay, that's not serious, right? But we're going to change our diet. We're going to give them on medication so they don't have a heart attack. Same thing with the brain. What these TIAs are is there's a narrowing where there's less oxygenated blood going to where it needs to go. The way we look at it is if you have TIAs, it's going to be, if we don't do something, eventually you're going to have a CVA. You're going to have a stroke. So the TIAs are kind of like that angina of the heart where, hey, there's some narrowings, we need to do something about it. TIAs, there's some narrowings, we need to do something about it. So we're going to put you on antiplatelets and antiplatelets and anticoagulation. Okay. Now the problem is when you're talking about TIA versus angina. With angina, we can go in and look around the arteries of the heart, and we can, clean them up, or we can do a CABG, which is a cardiovascular graft. Okay, so we can take other vessels and move it around the heart to go past those blockages. When we're talking about a TIA CVA, we can't do that. Okay, there's no way we can go up there and clean out the plaque of the brain. We can't do it yet. So if we don't take it and do something about the TIAs, then the patient's going to end up with a CVA. And that could be a ischemic stroke where it just blocks and there's no oxygen, or it can be a hemorrhagic stroke, which maybe they fell, or maybe their blood pressure was so high that the vessels were weak and they ended up with a hemorrhagic stroke. Alzheimer's disease can happen. There are people that start having Alzheimer's or symptoms of Alzheimer's disease starting at like 40 years of age. Hallucinations, they think people are there when they're not, or they think they're back, when they were a kid. Illusions, another thing, people walking into their room or hearing things, and then dementia, where they can't recall much, and they are awfully confused. Change in sensory functioning, cataracts occurs when the lens of the eye becomes cloudy. Usually they're opaque and causes blurring. We can get rid of cataracts. The one hospital I used to work near, it was cataract day was Tuesdays. So they would go in to get their cataract surgery, and then they would come to Eaton Park and eat. So I'd have a dining room full of people with patches over their eyes. It was kind of interesting. We knew it was cataract day. Glaucoma is an eye disease characterized by intraocular pressure. When you go to the optometrist, they usually do that puff of air into your eyes, and they can measure how much pressure is in your eyes, and we can watch that. Okay, age-related macular degeneration, basically destruction of the area in the retina where the optic nerve attaches, and it leads to blindness. So let's just say that word, presbycuous, the normal decrease in hearing that accompanies the aging process. Well, there's a problem with that. They are unable to hear alarms, sirens, phone, so it's a real big safety issue for them. What are we going to do? Well, we're not going to try to shout at them, because shouting doesn't mean they're going to be able to hear. Okay, sometimes we just have to go into a lower tone, and that will help. Lower tone, lower pitch. We can slightly raise our volume. We can raise the volume of the TV, and they should be able to hear it better. Also, what we don't talk about is there's a change in taste. They're less sensitive and need stronger flavors. About this time is when everybody loves sweets. Even when they were growing up, if they didn't like sweets, they want the sweets now. Okay, so there's a lot of nutritional concerns. We want them to have protein, and let's face it, a lot of things that are tasting sweet doesn't have a lot of protein or nutrients in it. So we try to give them a nice, well-balanced diet. Changes in cardiovascular functioning, heart muscle loses its elasticity with aging, the heart gets tired. Okay, when we're talking about people that are aging, blood vessels narrow as arteries collect fatty deposits, and peripheral pulses are less palpable. Okay, that's just part of aging. Okay, remember when you look at somebody's veins and they're little a little lady and they have little veins, and it's because of those fatty deposits. Okay, it just starts adding up over time. Circulation is decreased. Conditions that may result in decreased circulation could be CAD, hypertension, high cholesterol levels, myocardial infarction, or peripheral vascular disease. And this is why you have your little ladies that are in the restaurant and they are wearing sweaters when you might think that it's too warm out to wear a sweater. Their feet get cold, so they're always having slippers on or they always have shoes on. My grandfather was older and he would always have a coveralls on and the heat was always on. Even in the summer, the heat was on. He was very thin skinned, and he just got cold really easily. He wasn't like that when he was younger, but when he got older, that's how he was. It was heck to try to sleep in his house at night because of the heat. But that's what's going on. Okay, not only is a decrease in their vessels, their skin gets a little bit lighter and they don't have as much adipose tissue. That adipose tissue can keep you warm, so they're unable to stay warm. Changes in respiratory functioning, we reduce the flexibility of the lung elasticity. It doesn't work as well as it used to. More susceptible to lung infection. They also decrease immunity. So, it's very important for them to get those flu vaccines and pneumonia vaccines because they don't have, their immunity is lower. Also, like vitamin C and zinc can also help. Alveoli do not expand fully because of the loss of elasticity. One thing that we also want to mention is pneumonia. Even a cold and pneumonia can often kill our patients that are elderly. They have different signs, and like if I got pneumonia right now, you would hear me hacking up a lung. A lot of times their cough reflex is not there all the time. It doesn't react like it should. So where I would be like coughing up a lung, they might go. It's not really good. Okay. What happens also is that they have so many doctors that they don't want to go to this doctor for a cold. And then it goes into pneumonia, and maybe they can't get to the doctor now. Okay, maybe it's just them, or they're just sick of going to doctors. And then when they come into the ER, they have pneumonia. They end up a lot of times they're septic, and that's what kills a lot of our patients that are elderly, is because they wait so long to get the antibiotics that they end up passing away because that infection gets into their blood system. So we have to teach them every time they come in, signs to look out for. Okay. Let's see what we have next. How I was not able to go back. The one thing I wanted to let you know, whenever it says capacity of bladder decreases, nocturia is a problem, which means they have to get up in the middle of the night and pee. That causes an increased risk of falls because they have to get up at night. Maybe their bathroom's downstairs. So we have to, when we're in the hospital, we definitely keep an eye on that. That's why we put bed alarms on. Also, they have a higher risk for UTI, like pneumonia. When they have a UTI, they don't want to go to the doctor, or maybe they just don't feel there's a problem. By the time they go to the doctor, a lot of times it's turned into sepsis. And sepsis can be fatal for our elderly. So those are like the two biggest things we have to worry about is pneumonia and UTI, because that can lead into sepsis. Okay, where should we go now? Next is in the reproductive system. Older adults experience normal decrease in hormone levels as they age. Men will experience decrease in testosterone, which causes erectile dysfunction. We do have medications for that. But erectile dysfunction basically happens because of diabetes and chronic kidney disease. Could be because of alcohol. could be arthrosclerosis and vascular disease. We have to be careful with the erectile dysfunction, because if they can't, a doctor might prescribe like Viagra or Cialis. The problem with that, those are nitrates, and so if they also have, if they're taking nitrates for angina, for cardiovascular disease, that can drop their blood pressure significantly. So they might have to go another route. Another route that they could go to is actually a penile implant that a urologist can do. It's usually a 1 to 2 days surgery. So they'll go in the first day, and we usually discharge the second day. The oldest person I ever recovered from a penile implant was 85 years old, and he lived in a nursing home. Something tells me that he was pretty hip in that nursing home. Okay, and he did great. We've had other patients that came in for the penile implants, and like we had this 40-year-old, and the penile implant, he ended up with a huge hematoma that was in his testicles. It was pretty bad. But I was like, what do you say to your friends that are coming to visit you? You know, if it was appendicitis or something like that, we'd be telling. But I wonder if he really told why he was in there, because we ended up having him for about a week. But anyway, I figured I am not telling as many stories, so I figured you'd like to hear that one. Okay, women will experience decline in estrogen. Because they're decreasing estrogen, they might have vaginal dryness and atrophy. Also, that's about the time that they're going through menopause. They should be probably done with menopause. Menopause is about age 54. So without that estrogen, they're more apt to have osteoporosis. But if we would give them more estrogen, they are at a higher risk for cardiovascular disease. The decrease in hormonal activity can change the older adult's sexual drive. Okay, let's not get stuck with the stereotypes. Okay, do not assume older individuals are not sexually active. Hence, my little 85-year-old guy, or interested in remaining sexual active. Okay, I don't know if you know, but Florida has the #1 STI population in the elderly. So don't think because grandma's in the nursing home, she possibly is not celibate. Okay, I guess that's a good word to put it. I've heard stories about people in Heritage Woods going down the back stairs because they don't want their friends to know where they're going. So yeah, don't be stereotypical that old people don't like to have sexual encounters. I guess that's a good way to put it. Okay, changes in musculoskeletal and integumentary functioning. Well, not only because we're losing our estrogen, we have a decrease in bone loss and muscle loss, increased risk for injury. We have osteoporosis, and osteoporosis can happen in women and men. Most often we think about women because we lose our estrogen, and the estrogen, it lets the calcium bleed from our bones. But men are just as apt to have it. So we have them eating calcium with vitamin D, hopefully get that calcium in the bones. We also have new medications like Polaria, which I think is like every 6 months. But it's hard on the kidneys, so we have to do some lab testing before we actually give it. Decrease in muscle fibers and motor neurons can cause a decrease in muscle mass and strength. Skin becomes less elastic, the more prone to drying and break down, like skin tears, right? I hate when skin tears happen because a lot of times they're harder to fix. Nails thicken and skin bruises easily. That's where you get those nice talons when people on their toes, their toenails. They can be very vicious if we let them be. K, the loss of subcutaneous fat and decrease in sweat glands density over time changes the water abilities to thermoregulate. And I kind of went through that a couple of slides ago. Grandma always wearing a sweater. My grandfather always wearing coveralls, even in the middle of the summer. That is all due to the loss of subcutaneous fat. Psychosocial problems of the aging. Other concerns of older adults and their caregivers are the following. Fears about the dying process, as some people struggle with spiritual beliefs. I believe in, like, you're in with the church when you're younger, and then you get into your late teens, 20s, 30s, you might fall away from the church. And then when you get in your 50s, 60s, 70s, you find your way back to the church. I think that's usually the cycle. Of course, some people are really good and are churchgoers their all their lives, but I think, let's face it, spiritual beliefs is a very personal thing. So as nurses, we just have to be there for the patient and not put our spiritual beliefs on anybody else. We had a patient that was an atheist, and he was dying, and she prayed with him. Pissed the family off something fierce. He was an atheist, he didn't believe in God, and there she was praying for him. So be careful. I mean, you can pray for somebody like that atheist, but don't do it in front of him, especially not in front of his family. Okay, loss and grief as friends, family die, leave. Everybody changes. Some people might move away, some people might go to Florida, some people just have other activities that they're doing. Safety concerns, including scams and crimes. I mean, let's face it, there was a lot of safety concerns. Social Security Administration calling you, and if you don't call them back with your debit card number, you're going to jail. I mean, if you're isolated, you have nobody to talk to, that might seem like a real thing. Elder abuse by caregivers, we do happen to see that. People want them at home because they get that Social Security check, but are not willing to take care of those people at home. They often abuse them, and I don't mean physical abuse, but it could be just verbal abuse, or not give them the things that they need to thrive. Not looking at their best interest. Financial concerns regarding retirement and living. Well, at this point, I don't know who can retire. It's pretty ugly, retirement, but if they do retire, maybe they have to retire because they can't move it well anymore. Do they have enough in their 401k? Do they keep a 401k? Are they going to have enough on their Social Security? And if they don't, how are they going to be able to feed themselves? That's when we have to get other resources involved. And they increase dependence on others, and that sometimes sucks. They might need help taking care of their house. They might need help bathing. When you're talking about somebody that is very independent, it is a very big mental issue for them. Oh, dear Lord. Caring for patients who are dealing with loss and grief. We can refer them to support systems. We can educate them on the importance of proper nutrition and exercise. The thing is that, if they don't get the right nutrition, they are probably just, their immunity is going to go down. So we need them to have the right nutrition to prevent illness. Exercise can relieve the tension and stress in their life. We want them to be able to encourage rest. We want them to help find comfort and healing, and we're going to help them. Encouraging spirituality and spirituality, and allow patients to grieve. So we want them to have time to express their feelings. We want them to share their stories. We might want to contact some religious person in their life. If they're Catholic, maybe they're not practicing Catholic, they don't go to church every week, but maybe invite a priest to come talk to the patient. Okay, it's not unheard of. The chaplains are very good also. You can invite a chaplain to come talk to the patient. because it's just a comfort. I'll be honest, I said I'm not a really good Catholic. I don't go to church every Sunday. I used to. In fact, that was a New Year's resolution and back in 2020 that I would go to church every Sunday. And we were doing real good, and then COVID happened, and to me that was like God sitting there going, yeah, you thought you were doing good with this New Year's resolution? Watch this. And it's been a challenge to go to church after that. I got to get back going. Anyway, we're also going to provide privacy and silence. Sometimes just being in a room is enough. And also let your patient know there's no formula or a timeline for grief. I think you guys realize this, that everybody grieves differently, and they grieve for different reasons. So somebody might think, hey, day one you grieve, day two you're in acceptance. No, it doesn't work that way. And the patients need to know that too, that they have to work through their grief and come through the other side. The only thing I do tell patients sometimes is when they're grieving, I should say families, that this moment is the worst moment in their life. You know, that hopefully from here it'll get easier. And that's if I'm very close with that family when that patient dies. You know, it's not something that I share with a lot of people. Okay? Concerns, 60 to 65 is usually when we retire. Workforce, some people stay in the workforce until the age of 70. Sometimes it's just for something to do so they don't become stagnant. Other times it is because of financial concerns. That Social Security card check is not enough. So they try to get, supplement their income. They might express concern over bills, and my parents, I think they're well off, but my dad will sit there and say that he doesn't have enough money, and it's because of the fact that they don't know what could happen. So if they need a water heater and they don't have the money to pay for a water heater, how are they going to pay for it if they don't, keep an eye on their money? It's not like my dad's 83. It's not like he can run out and get a job to pay for that water heater, although he probably could. Um, just saying hi at Walmart or something. But, by the time you say hi at Walmart, how many weeks do you have to work before you can buy a water heater? Imagine they're pretty expensive right about now. So that's a big concern. And concern about living arrangements, well, maybe the mortgage is paid off, but can they afford a water heater? Can they afford air conditioning? Maybe the roof needs a new roof. How are they going to pay for that if they're on a fixed income? It's not like they can pick up hours, get more Social Security. So I can see where it's a real concern. If I need extra money, I pick up more hours. I can go to the hospital. I can pick up some work on the side. I feel I'm going to be one of those that are going to be very concerned about my financial concerns when I retire. Not even seeing a day that I can retire anytime soon. Okay, the nurse should be empathetic, therapeutic listening, and refer to the patient to appropriate resources for assistance. Definitely. There's a lot of resources out there for our elderly, for them to be able to live comfortably. They might not be living like, who am I going to even think of? Who's rich? Like Beyonce or Taylor Swift, but they can live comfortably in our community without much fear. Okay, positive aspects of aging, wisdom and knowledge, various life experiences. Talk to our patients. I love talking to older patients, them telling us about their different experiences. Older individuals have knowledge to share with younger generations and be respectful to allow them this positive time. So don't run out the room. Let them talk about it. You know, when we go to Fireside, there are some really good stories out there. I love listening to my grandparents talk. And you know what? If I don't tell my kids those stories, it's lost. You know, I remember whenever I had my first child, I tried to get my mom to write in a book, you know, about her life and everything like that. And she never did it. Now she can't. And all those stories that she told are probably going to die with her. Doesn't that suck? Think about that. Things that you would want your future children, grandchildren to know could actually die. That's sad. Okay, on to better things. Okay, residents' needs. Wow, back to Maslow's. You guys know Maslow's, right? Been there, done that. With our concepts map. So they need oxygen and fresh air, water, nutrition, and a healthy elimination. They need rest and sleep, comfort and pain, optimal health, safety and security, spiritual edification, freedom from anxiety and fear, and love and affection by others. It's all about Maslow's needs. Self-respect, and being respected, self-esteem and self-confidence. Sometimes our self-esteem does fail. Okay. Productivity, self-worth, and simple enjoyment and fulfillment in daily life. So all the things that we try to bring to our patients, our residents, our family members. So helping to meet residents' needs. Well, when we're talking about resident rooms, clean and personalized, put some pictures of family up there. And you see at Fireside, some people are they have their rooms so nice. There's a lady, I don't know where her room's from, but she's from Hoffman. She has her, her dresser in there that she had from her home that she lived for in 60 years. She had pictures of her husband and her kids and everything around it. She really made it a home. And then there's others that it just looks like a room, and that's it. So we want to personalize it, make it their own. Okay, label their clothes. We don't want Susie to wear Jackie's clothes. Personal care, hygiene, allow them to assist. Don't assume that they can't help you. Don't assume that they can't wash their own face or brush their teeth. Okay? Let them do what they can. Even if it takes 10 minutes to do it, just do it. Nutrition and hydration, dentures, consistency and assistance. If they don't have good dentures, maybe they keep falling off. Well, let's get them a different diet so that they can chew and eat. Elimination and toileting. Sometimes they're incontinent, so let's make sure they're not, sitting in their own feces or urine for long periods of time, and then they would have skin breakdown. Immobility, okay, that's tough. You notice everybody at Fireside has a wheelchair, except one person. That one guy can walk really well. But that mobility to get them up and moving, if they didn't have wheelchairs, they'd be stuck in their room, and that's no good for anybody. Activity, entertainment, crafts, nails, getting their nails done, music, bingo, etc. If maybe they were not able to do bingo, but maybe they can go and we can play bingo with them. Okay, get some interaction in there. And medication. We have to be careful with our vital signs and our documentation that we don't over-medicate our patients. I mean over-medicate because their liver and their kidneys aren't working. So things like amiodarone. If their liver's not working well, amiodarone is a dysrhythmic, and it actually stays in your body for 60 days before its half-life. So you can imagine if the kidney and liver is not working like it should, how much that amiodarone is going to be swirling around their body. Okay, so we have to be very careful of these medications that we don't overdo it on them. Okay, intermediate care used for health conditions that require daily nursing attention, but not 24-hour nursing care. So it could be that they just need help getting a shower or a bath. Maybe they need to get help just getting up. Skilled care means that they need IV therapy, physical therapy, and wound care management. So that's why they would be with us, 24 hours a day, because it's things that you have to have a skill to do, nursing skill or PT skill. Working with older adults continued, memory care. When we're talking about Charlie Manor, a lot of patients, they're 24-hour nursing, but then they go to memory lane. It seems that they do a lot better at memory lane than they do when they're not in there. It's just the different kind of nursing that they have. Okay. Assisted living requires little or no care for the patient residents. They just need somebody to remind them to take their medications or remind them to go down to the dining room. There's activities for them to keep them going. Okay, of course, I believe Heritage Woods is a lot more expensive than the nursing care, because I don't believe Medicare picks up for Heritage Woods, but I could be wrong. I thought Heritage Woods was probably mostly all private pay. Could be wrong though. Okay, assessment considerations for residents in long-term care. Their general appearance. How are they looking? Do they need adaptive equipment? Do they have the ability to communicate? Level of cognition. General eating habits. What do they usually eat? When do they eat? Some people go to the dining room. Some people stay in their rooms. Some people don't like the food there at all, so they have little, things that the nurses put in microwaves. Special nutrition assistance. Like I said, a lot of people like sweets. What else can we get them to eat that's nutritious? Bowel and bladder elimination status. Do they leak? Do they have an overactive bladder? Or are they unable to get to the bathroom in time? Okay, assessment considerations, ambulatory status. Can they walk? Do we want to keep them walking? Everybody at Fireside has wheelchairs, but can we get them to the point where they can use a walker? Their sleep habits, what do they need to do before they go to sleep? What time do they usually get up? Okay, what kind of medical equipment? Do they need oxygen? Do they need a CPAP machine? Okay, and then activities. Can they go down and do activities? Do they like doing activities? Is that something that they're interested in? Some people just want to stay in their rooms. But we should be able to offer them, at least offer them to be able to go down and socialize. Polypharmacy, because they have all kinds of different specialists and providers, they have all kinds of medications. So when we talk about polypharmacy, we're talking about the ingestion of all those medications. There can be a cumulative effect that can cause an adverse reactions, drug-to-drug interactions. So we want to be cognizant of that. Ideally, the providers should talk back and forth to each other so they know what they're giving, and any kind of adverse reactions that they're on medications they're already on. Okay, they should. A lot of them do, but we just have to make sure. Patients really should know what kind of reactions they should have, with these medications. Some of them might not know the exact name, but they know that white pill makes them pee. That blue pill brings down the heart rate. The yellow pill's for their stomach. They might know them by that route, which is not the best route to know, because if they're in a nursing home, it might be a white pill that causes them to pee there, but it might be a purple pill at the hospital. So we should go over the names with them, just so they're aware of what they're taking. Also, patients in jeopardy of overdose or toxicity due to the fact of decrease in their kidney and liver function. We also should keep an updated list of their medications personal people, people that aren't in the home, in the nursing home, should keep a good list. We can't print it in September and expect it to be the same list in July. Okay, we should update that list regularly. I would say 70% of your patients, every time they go to a doctor's office, they're going to get a new medication list. So we have to be aware of that. Make sure that that we update that list. Okay, it's that time. Clicker question. Glaucoma is an example of what kind of physical change in older adults? Gastrointestinal, cardiovascular, sensory, respiratory. What do you think? Yep, you're right. It is sensory. It's about that ocular pressure. Next, when a patient is taking multiple medications, a potential for what complication arises, and what are we going to say? Yep, polypharmacy. Term polypharmacy refers to ingestion of many medications. It is common for older adults to have more than one healthcare provider as he or she has developed various conditions over time. Well, thank you very much for listening. I hope you enjoyed this. And if you didn't, well, you could always just lie. Thank you very much and have a good one.